Hey there, welcome to Chairside Live. I'm Megan Strong.
And I'm Will Schmidt, Registered Dental Assistant here at Gladwell Dental.
And in today's episode, we're picking up where we last left off with you, and we're moving on with your case. This is part 2 of your scan school, and now we're moving to the upper arch.
That's right, we're moving onwards and upwards with a full arch, pre-treatment scan, a bite registration, and we're going to go through the steps to send this case to the lab.
Well, let's get started. Let's go.
Welcome back to iTero School. Class is once again in session. Let's continue here where we left off in the last episode with our patient's pre-treatment scan. As a quick recap, I have already explained how to locate or add patients into the system, the proper seating position, and then I initiated and completed the full lower arch scan. We are scanning this patient pre-treatment. This is for initial records or for diagnostic models, Invisalign treatments, or even appliances such as sports guards and night guards. Even if you already have iTero experience, this is a great basic skills refresher course to help you develop those skills just a little more. I'm going to get started today with the maxillary arch scan. When we convened last episode, I was briefly talking about the 2 different view modes that can be used during the scan. I mentioned that I prefer scanning in the grayscale mode, but for this maxillary arch, I'm going to scan in the high-resolution mode just to show the difference. To start, I'm selecting the maxillary arch on the left side of the screen, and it will save the previous scan and clear the screen for this arch. I'm seated once again at the 12 o'clock position, and I've got the scanner to my right at about 7 o'clock. The scanning wand is in my dominant hand with my palm and fingers facing upwards, just like the lower arch scan. My opposite hand is at the ready, but stabilizing as a fulcrum base. In this case, she has her third molar number 1 present, but not number 16. Now, to make it easier on this patient, I'm starting with the possibly more difficult quadrant first. This is the one with the third molar present, so she doesn't have to open or stretch as wide as she does now towards the end. Starting as distal to the most posterior tooth in the arch as I can, I start this scan by tapping one of the buttons found on each side of the wand. On this first pass, I'm acquiring occlusal records only. As I'm wrapping around to the anterior of this arch, I need to stay more lingually inclined rather than looking straight down on the incisal edges. Remember, incisal edge detail on a full arch is always the last step. Contrary to the grayscale scan mode, blue instead of red will indicate the data that has not yet been captured. I'm going to stop that scan and review what we have already captured up to this point. Starting once again from the distal of the third molar on the upper right quad, I'm going to scan the lingual next. Now, I can't mention enough times to make things easy on yourself and start on the occlusal surface first, scan for a few seconds until the old and new data meshes together. Once that scan appears on screen, I can turn the wand to the lingual and start to move around the arch. I'm most concerned here about scanning the embrasures and undercut areas of the lingual. Really pay attention to the wand position. I've turned it so it faces almost straight up to the ceiling, and I will twist it with both hands if needed, as you can see here, laterally left and right, and move along the arch. Bold and purpose-driven smooth movements are the key to success in this case. The scan looks clean, so I continue to the buccal. Well, I'm just asking her to loosen and relax her lips a bit before starting this buccal scan. Patients in general tend to keep their upper lip tighter against the teeth more than the lower, so I'll just create a little clarity in my expectation of their positioning before I get started. So beginning from the distal of the most posterior tooth in the arch, I'll once again scan the occlusal until the previous scan meshes together and then move towards the buccal. I'm still rocking the wand with a lifting motion from the tail end up and down for interproximal areas, and then I'll stop at the midline. The distal of the adjacent quad's molar is reached by asking the patient to close down slightly to give it more room. I'll wrap around to the midline and then get the incisal scans to finalize. All we need to do here is rock the wand buccal to lingual over the incisal edges again. Start more towards the bicuspids until the mesh happens, and then rock the wand buccal to lingual, moving towards the midline. I am reviewing the final scan now, and I notice a bit of untouched information mesial of tooth number 3, and that's designated here by this blue spot. I don't want to simply rescan back over this area. This scanner is picking up images at a rate of 6,000 still frames a second. We want the scans to include as little layered data as possible, while at the same time acquiring all the necessary elements. In this case, I'll use the fill feature. This allows only the missing areas to be scanned into place to avoid multiple layers. By pressing and holding on the screen, this reveals a new menu with a few options. This allows you to delete an entire scan, erase segments of scans, as I'm doing here, just painting my finger along areas that I want to remove, or as a last option, fill in the missing data areas. I'm pressing on the fill button and the element will take a moment to search for possible missing data and then circle them to be scanned. Now that the data search is complete, it's found a few areas that it suggests may be voids that need to be filled. This is simply a guideline, and you determine which areas do, in fact, need to be scanned over. Like I mentioned, the beauty of using this feature is that only the voided areas are being scanned into, and multiple layers aren't being placed on top of the existing completed scanned areas. The reason why I've got to stress that this feature is simply a tool to assist with missing data acquisition, and you can see here in this screenshot, is that the data I wasn't able to acquire on the third molar wasn't auto-marked to fill in. In situations such as these, there are three options at your disposal. The first option is to attempt a rescan of the missing areas. I found this reattempt to be in such a tight area that I even broke my rule about using retracting devices and enlisted the help of a mouth mirror. I was able to scan just a little more, but I don't fully have the molar anatomy like I would want it. The second option, and one that isn't recommended under many circumstances, is to let the program autofill the missing area in post-production. In other words, when we finish all required scans and the program prepares the data to send to the lab, it will fill in the missing data points with ideal anatomy. This option is fine if it doesn't impede the outcome of the final product that you're requesting. For example, if I'm scanning this patient for a diagnostic wax model from, say, 4 to 13, I'm confident that, in this case, the autofilled information isn't going to interfere with the outcome. However, if this is being sent for a form-fitting maxillary appliance, I may want to rethink the autofill option. As you can see by these still shots, the ideal anatomy that the autofill chose really isn't the smoothest transition and may just interfere with some removable appliance's fit and function. Now, I wanted to show this patient specifically as a training tool. I've learned that no matter how skilled you may be at the scan process, there are times when anatomy and angulation simply prevent a tooth surface from being reached, which leads me to option 3, and that is, after all other methods have been exhausted, you are absolutely sure the data can't be acquired, and the missing area will definitely interfere with the final product, then the only choice is to revert to taking a manual impression. The chances are substantially minimal that this is going to occur, but it does. And in real-world dentistry, we aren't going to learn anything when presented with the picture-perfect example every single time. Moving back to our pre-treatment scanning steps, I'm going to assume that, for this case, the missing third molar data is not going to interfere with the outcome, and I'm going to get ready for the bite registration process. I'm going to switch into bite registration mode by clicking on the icon of the bite located between the arches on the left side of the screen, and you'll notice now that our upper and lower scans are staged opposing each other on the screen. The bite needs to be taken bilaterally, and it is your preference as to where you'd like to start. I'll ask this patient to open wide, and I'm going to place the wand in the vestibule, and then ask them to bite again and press together in their normal centric occlusion. I'm going to keep a close eye on the real-time view screen on the lower left of the monitor just to make sure that they never deviate from this solid bite. I can tell fairly quickly if any movement occurs. This scan only needs to recognize the arches and then bite them together once the process starts. I'll press one of the start buttons on the wand and then begin the scan towards the anterior in a large S or a zigzag pattern. The moment the program bites the models together is a perfect time to start the scan. At this point, it should merge pretty quickly. I'll move over to the opposite side and perform the same steps until the bite's found. With an image acquisition speed of 6,000 frames a second, it is important here to end the scan right after the arches merge. Let's go ahead and send all this data for post-production. On the top of the screen, I'll press on the Post-Scan Case Review button, and it will send all the scans into post-production. Depending on how much data was received during this entire process, the length of time it will take the iTero to complete this step will vary. Now that the processing is complete, I've got a smoother, more readable view of the final scans before sending them out. I'll do one last review to make sure everything I want to scan has been documented, and then I'll click on the Order Authorization button at the top of the screen. From here, ask my doctor to sign the order. This will give the doctor a chance to final review the scan and approve it as well. The option also exists to save the dentist's signature and send it on their behalf as long as they've given pre-approval. This stage also gives you a chance to go back and review the completed prescription page if you'd like without losing any data. When all items are ready to go, Press the Confirm and Send button on the Order Authorization tab and let the transfer complete. The screen is going to switch right to the Orders page, and we can see here that the order status is marked as Sending. Just let the iTero continue to send the case, either to your in-office design software or to the lab. In the meantime, if you do need to use the scanner for another patient, this is perfectly all right. It will not affect the current project status. Once the order has finished sending, an ID number will be created. This allows you to reference the case if you need to contact the lab or for any other reasons. Otherwise, this patient's scan appointment is complete.
Thank you for that, Will.
Not a problem. And if you like those episodes, there's more in store. I have plenty of content when it comes to digital scanning.
Well, I'm setting my alarm, marking my calendar.
Please do.
But for today, that's it for this episode. So on behalf of everyone here at Glidewell Dental, thank you so much for watching.
And we will meet you right back here next time.